Because when you work, you're going to have to be engaged for 8 to 12 hours. So believe it or not, the things that you do in here do translate. Eventually, you'll have to learn it. So if you practice it here, it will make it easier, believe me. So when you are in practice, you have to be on 8 to 12 hours. You have to, your brain has to be on. So I know it is weary. I can see it in your faces. So somewhere inside, you have to kind of bring it back up or re-engage it or get enough of a break that you can get your brain back in it. But it does really make a difference. When I leave clinic, usually, my clinic days are usually 10 to 12 hours. Mostly 8 hours of seeing people, and then it was all the paperwork as the administrator, so I had other stuff that I had to do. I always felt like someone, you know those alien movies where they stick tentacles in you and they suck them? That's what I always felt like. Somebody had put tentacles to my body and had sucked the life out. That's the way I felt at the end of clinic. So I'm telling you that these, even though the days are long, they are good training. The other thing I would suggest, which you all, for many of you are good at this, be here and ready to engage at the time the class starts, whoever is here. Okay? You cannot walk into clinic 5 minutes before it starts and be ready to go. You cannot do it. You have to do about at least 30 minutes, I would say. You have to get yourself in the place, ready to go. Everything will, because things will always fall apart. So your tech won't show up, your nurse won't show up, the computer is down, somebody is having a major meltdown that they want you to address, there's a blow up on the schedule, 3 people walk in that didn't get loaded and they all want to be seen at 8 o'clock. Okay, so I'm telling you, walking in at 2 minutes till will not work, so at least 5 minutes ahead, get in here, get things ready, and get your brain engaged. That would be my suggestion as practice. For the most part, you do that. But it told on your face a couple of days ago how in every class I've seen so far hits this lull. It's summer. If you're into a usual class or academic schedule, you may be used to being off in the summer. So it's normal. Summer is more of a lax time in our culture most of the time. So I can see it on your faces. So it's normal. I remember the first time, I went to college for 11 years. So the first time I hit it December, when I wasn't in school, my anxiety level started going up. And finally I thought, you had no finals. You don't have to worry. But you get into that cycle. So I do understand, I do. But so some of it is understanding, but also is figuring out how do I address this new demand, sustaining demand. And it's hard. It's not easy. If it was, you all be very rosy looking. You mean you're not? You have moments also. Okay. All right. Questions? Anything up to this point? Housekeeping or content? I do not know what materials on the test. So when Professor Warwick is planning to come down later, so let's confirm because you all are telling me things I wasn't sure. So I figured out why I was teaching you stuff before you had it. I was trying to carve out about 10 to 12 days where I could be off to clean out one house and get my other one set up. So I push things both ways, and so that's why peptic ulcer disease and all that. But I understand some of that material may be on the second test, so she may be also expecting that my stuff is on that second test. So I'm going to ask her to clarify today. Okay, but you have had irritable bowel syndrome.
Yes.
Okay. All right, so let's talk about it. So you know it's divided into IBS, constipation dominant, diarrhea dominant. So that's the one thing when you're looking at drugs and how to treat, you're going to look at what is the patient complaining of, regardless of how they have been typed. Because people can certainly have a mixed pattern. They can have symptoms that dominate at one time and not the other. But our drug therapy, we've now got enough drugs out there. I wouldn't say they're all great, but they do address specific symptoms. And there's somewhat of a hierarchy of how to approach them. So that's what we're going to do today. So at the bottom, dietary management is going to be foundational. So mostly it is geared towards what aggravates their symptoms and eliminating those. If they really are having a lot of trouble with food, I would get them into a dietitian. It could be that, we talked about the FODMAP and getting them on a very restrictive diet and then adding back things and teaching them. A lot of times patients know, yes, that always causes me trouble. But sometimes there are foods that are causing them trouble they may not have identified. So gas-producing foods, they're listed there for you. So eliminating those or looking at amount of, or not putting them together in one meal may be very helpful. Lactose intolerance, sometimes it's helpful to remove lactose and then add it back in. Even though it is not, these folks are not lactose deficient usually, but it may be aggravating, or they may have both. They could have I'm moving to age 30. The FODMAP diet, what is that? What are those? Fermentable, oligosaccharides, fructose. So, and they cause trouble, why? Because we're not metabolizing them or breaking them down in a digestible way until they get to the colon. If they make it to the colon, then what happens? The bacteria ferment them, and then you get what kind of symptoms? Gas, abdominal discomfort. They can have diarrhea as well. Okay, so again, I would find a dietitian who can work with them because it's a very restrictive diet for a period of time, and then you're adding foods back in. Teaching patients how to read labels and look for those products in there as well. Also, you don't want them to avoid big food groups that could cause nutritional deficiencies. So working with somebody who can work with them would be very helpful. It is the one diet that has evidence. Did I put it here? I may have put it in the earlier part, but there are studies that have looked at these diets in IBS patients and have found them to be significantly reducing symptoms. So keep this one in mind. Gluten avoidance, they don't have to avoid gluten, just like they don't have to avoid lactose. They may feel better. It may be something they could remove, but they don't go hand in hand. So don't impose another restriction on them. Let the dietitian work with them, and we want their gut to get good nutrition so they can heal, and they can also get the nutrition out of their diet. Fiber. So fiber is controversial. Some people it improves symptoms, some people it makes it worse. Soluble fiber is the one that is the most helpful. Insoluble probably gives them more symptoms. So we want to, if they're on a low fiber diet, we want to increase it as they can tolerate it because it's good for health, good for gut health. So soluble fiber would come from what type of foods? Oats. Some vegetables do. So go back and pull out your nutrition handout, because we talked about these. You're getting far enough along that there are things that have already been laid down foundationally in your curriculum that go back and look at them. I guarantee you if you'll just read back through them, your brain will go, okay, I've seen this again, I'll store it away. And if you'll give your brain more and more opportunities to tie things together, it will do it. And one day you'll wake up and you'll go, oh, and that's a sweet spot. So just read back through them. I'm not saying study them, just read it through. And you'll go, oh, okay, got it. And maybe it'll take 10 times of those, but it will become more clear. Okay, so soluble fiber. The symptoms we usually look for in IBS, one is abdominal pain. We want it to go down. We want their stool consistency to improve or to be consistent. We want them to not be constipated, not to have diarrhea. So we're trying to move them more to normal. Their quality of life. You know, can they go places and not worry about, do I know where the bathroom is? Okay. So if you're going to use a fiber supplement, you start low and move it up as they tolerate it. Okay, so Metamucil is the one we're going to prefer. That's psyllium. It's a soluble fiber. It adds bulk to the stool. Also will bring in water, makes the stool usually easier for them to pass. So it decreases usually the constipation. You can titrate it up to as often as having it with every meal. So start with about a half a tablespoon. The recommendation is a tablespoon, but even half of that till they're tolerating it, then they can titrate it as they are. As they tolerate and until they get effect. So, and it can be added on top of dietary fiber, so it's not exclusive for them. Bran is an insoluble fiber and can often aggravate symptoms, so that would be one to avoid or to decrease. So the bloating and the abdominal discomfort may go up there. So in terms of reserve for patients who don't tolerate fiber in their diet. However, you can supplement if they can't take in enough. Okay, next page. I talked about this under constipation before. Psyllium and polycarbaphyl are the two on the market. Psyllium is preferred because it has data behind it, has evidence. It has been used in trials, and so it has something to stand behind. And this is that one committee I was talking to you about, the Committee on Constipation. From the American Gastrointestinal Society. They have come out and they said psyllium is the one they recommend. Under abdominal or under adverse effects, diarrhea or constipation. You give too much fiber, you can see diarrhea. Too much, sometimes fiber, you can get constipation. So that's where that fine tuning is. The esophageal obstruction comes from people taking, I don't know why anybody would do this, but you can't take the powder without water. But it forms a gel, can be obstructive, can cling to the sides of the esophagus. So the tablet's the same way, taking things with plenty of water, getting it down into the stomach, and moving it on is important. Okay. The polycarbaphyl is a problem in that it does interfere with some absorption of nutrients like calcium. So if you have someone who has to take that, or that's what they choose, then educating them about separating them out is important. Okay. So that's your first. So fiber for constipation dominant IBS, fibers first. The next would be the osmotic laxatives. That would be if they're not responding to fiber, is to add those. So this is when we talked about constipation, we talked about this being the mainstay of chronic constipation. People don't have IBS. Okay. So these are osmotic in terms they draw water into the colon. Okay. Makes it easier to pass that stool, keeps it from being so hard. So good constipation reliever. You could use the electrolyte solution. So this would be like Go Lightly. That is the solution they use for bowel preps. Okay? But you can use them in small amounts. Lactulose would fall into this. The one that's favored now is Miralax. It's also a pegylated powder. So pegylated molecules are very hydrophilic. They draw water to them. And so that's why they're usually fairly well tolerated. You can titrate this one. It comes in a bottle. The cap is the measuring tool. Okay. It marks it off at 17 grams, so that's the starting point. And you titrate it to effect. You can go up to 34 grams. Most people do well in that range. Usually it's once a day. That's another good thing about this product. Yes.
I've heard before with Miralax, I have no idea if this is true or not, if you take it for chronically, that your bowels can kind of stop moving if you try and get off of it long term, and it kind of becomes worse. I don't know.
The stimulants are much worse at that. That's why they're always third line, PRN use. The osmotic, I think anything that you make a huge change in the gut abruptly, you're going to have trouble. I don't know that so much about the osmotics, but the stimulants, that's exactly right.
Okay.
So X-lax abusers, and so when they stop, they really do have trouble.
Okay.
So that maybe that's where what you're remembering.
Okay.
Taylor, I used to take Miralax every single day for like a year, and I don't have to take it anymore. So I don't know, that's just my personal experience.
Okay.
So the third class of drugs are these last two. These are if fiber and the osmotic laxatives have not worked, then you consider them. You would not go to these first, usually. So these are on, if you listen to commercials, which I know y'all are on listen to the TV, you'll hear these. So Amitiza and Linzess. These are products that promote peristalsis. Now, the first one, Amitiza, is only approved for women because that's where they did the studies. And it's approved for women who are not responding to those osmotic laxatives. The problem with these is that their side effects are more significant. And that's why they're going to be more second. And they are modest at best. Okay. So this one, the side effect with it is dyspnea. It's a weird, I can't tell you why it occurs, but it is in about 3% of women. So educating them if they do get short of breath. These are usually people who are not going to have dyspnea, but if they do, they need to be evaluated. And they're expensive. Now, Miralax isn't cheap, but these are about $350 to $400 a month, so they are quite expensive. Linzess is also in the same group. It is approved for men and women, so that would be the difference there. And with Linzess, it's a delay. It takes a while. Remember, I told you the gut, for the most part, is very adaptable. Sometimes when you make big changes to it, it takes a while for that to become a new normal. So with Linzess, it's a delay. So don't evaluate its full. If they're tolerating it, they're getting improvement. In about 3 months, you'll be able to tell if that's not. Again, very expensive. This one, it's once a day again, first thing in the morning. Okay, so those are the agents that we have for constipation. So it's fiber, osmotic laxatives, and then those chlorine channel products, the last two. So then let's look at IBS with diarrhea dominant. Here we've got, again, dietary modifications. What aggravates it? What seems to give you diarrhea or to set off your bowels? The next is loperamide. The third is that Viberzi. And also the bile acid sequestrants. And then the last one is Lotronex. I think y'all talked about that. I saw it up on the board. Okay. So that's the hierarchy of treatment. Again, the further down you go, the more the side effects get really significant. So we'll go through those as well. So loperamide, so here we've got, remember this is the one I told you that came on the market as a controlled substance. And then they found that the abuse potential in the majority of the population was low. So they took it off. It's no longer controlled and it's over the counter. The difference with here, compared to what we talked about, just diarrhea in general, is that usually you want to put them on a regular dose per day. You can also have them use it as in anticipatory. Let's say they're going somewhere and for the most part they're doing okay, but they do not want to deal with diarrhea. They're going to a special event. They can take a rescue or a breakthrough Imodium as well. So here schedule is better, and then on top of that having using additional for breakthrough. Make sure you know the max on that, 16 milligrams a day. Those are the big things with loperamide. I did tell you it can be used by abusers, very big doses of it. They can get that opium feel or sensations. For the most part, these folks are not going to do that. Constipation is the downside. So you're going to fine tune it to what keeps them more regular. Okay, the Viberzi is, it is a controlled substance. It works on two different opioid receptors, so you get a dual effect. That's why it's very effective. It's approved for both men and women. So look at what it does symptom-wise: abdominal pain, loose stools. So very effective there. The big side effect of it is pancreatitis, which can be fatal. So you have to talk to the person about their history and potential or risk factors for pancreatitis. Number one is if they do not have a gallbladder, then don't use this drug. So their ability to control bile is low, and that ability to aggravate the pancreas is high. If they've got a history of pancreatitis, if they're on other drugs that could cause pancreatitis, if their alcohol intake is high, then those are folks to avoid this drug. The next are bile acid sequestrants. So we talked about these in lipid, right? Okay. So often with IBS, you also have bile acid removal and clearance is abnormal. But these drugs are very good sequestrants. They will bind things to them, and they don't let go. So they're really good for people who they can't take Viberzi, they're still having a lot of diarrhea. These are great drugs. The biggest problem with them, and I told you this with dyslipidemia, is they're hard to use. They really need a lot of patient education. If they're a drug you're going to use in your practice often, that would be something you need to know about. If not, you need to find a pharmacist, or your nurse needs to have good education about doing this. In the VA, I worked with the veterans all the time because this was a preferred agent when I was there. And you can get people to tolerate it very well, but there's lots of little tricks and pearls to employ to get people to use it. But it's a very good drug. And any of the three would work: cholestyramine, cholestipol, or choleseveline. All three of those. They come as powders that can be mixed. Cholestipol comes as a tablet, so if people don't want to mix it. But usually teaching them to mix it up like the night before, it will congeal better, mixes better, and it's more palatable the next day. Always palatable cold, better than just mixing it and drinking it. The downside is that it can cause the same symptoms, side effects of the drug is the same side effects they will have. So it increases gas production, can cause constipation, abdominal discomfort. So again, it's titrating to effect.
I have a question.
Yes.
I know that you have said this before, but they will bind the bile acids and then prevent resorption. So
Right.
how does that decrease diarrhea? So if it prevents resorption, I would think it would increase.
Because they are like concrete. They just pull it in, and they are very hard and stabilize it.
Okay.
So they will.
So it kind of pulls it.
It doesn't bulk it so much as it binds it.
Okay.
So like psyllium will draw in water and expand. These drugs don't do that so much. They're more binders, and you just eliminate them. So it tends to harden a watery stool. Does that help?
Yeah.
Okay. The last one is Lotrenex. Lotrenex is in the same class as Zofran. So you have lots of serotonin receptors in your gut. And when we get to the SSRIs, the antidepressants, a lot of their side effects are gut. Diarrhea, constipation, and it's because of those serotonin receptors. So this is a drug that's been developed for that. It is last resort. So it's indicated for, is it women? It's women only. And it is after 6 months of trial of other drugs that we just talked about, and they have failed those, or not gotten adequate response. Then you can consider this. So it's for severe diarrhea. It blocks vagal stimulation. So the vagus nerve, big innervator of the gut. So it's going to block those. So it's gonna slow down gut motility. It can only be prescribed under restricted. So unless you're in a GI group, you're probably not going to prescribe these, but you may see people on them as well. Anything you learned about that anything you were told about IBS that contradicted? Contradicted? Okay. Last these are drugs that can be used in either constipation or diarrhea. So these are more for abdominal discomfort. And that would be pain and bloating. These are antispasmodic, anticholinergics. They've been around forever. They were the first drugs that were ever used for IBS and indicated for IBS. They are better if you use them on a PRN basis than on a chronic basis. There's two primary ones, there's others, but the two big ones are cyclamine or Ventyl and hyoscyamine, which Anaspaz, Levsin is another one. It comes as drops even that you can mix in water. So these are going to work off anticholinergic. So anticholinergic, anti-SLUT, constipation. So they tend to decrease gut motility and give relief from abdominal cramping. So their side effects are going to be anticholinergic side effects. Taking too many gives you that little under adverse effects. I don't use this, but a friend of mine loved it. Dry as a bone, red as a beet, hot as a hare, mad as a hatter, blind as a bat. Those are more the toxic effects of anticholinergics. The anti-SLUT that I told you tends to be more of the common side effects that people have. So they can get facial flushing, their body temperature can go up, they can get delirium too much, mydriasis, so their blurry vision. That's what all of those entail. Usually you don't see those at low doses. Okay. The hyoscyamine is the same. It's an anticholinergic. There's no one over the other. It doesn't matter. You're going for the anticholinergic effect. On the last page is antidepressant. This one is the TCAs. I know we haven't had that yet. Usually this comes, last year this came very late in the fall. So you had a lot of these drugs before. So the TCAs are one of the first classes of antidepressants that came out. In this group, amitriptyline would be a common one that would be used. Those group of antidepressants have several effects that are beyond their antidepressant effects. One is anticholinergic, so that would help. They also reduce substance P, which is related to pain. So we use them for neuropathic pain. So they can reduce pain and also reduce or anticholinergic, so decrease peristalsis. The SSRIs and SNRIs are not used. They have variable effects. They don't have the data behind them. Amitriptyline's been around for 50, 60 years. So lots of safety data. We usually use small, low doses. Higher doses, we get into more problems with the anticholinergic effect and conduction disturbances as well in the heart. So low doses, people usually do pretty well. It is a really sedating drug, though. We'll use those at bedtime in people with peripheral neuropathies because it helps them to sleep. And it also has that kind of foggy response in the morning. Remember when we talked about diphenhydramine, you talked about waking up in a kind of a fog. It takes a couple of hours to, it's a hangover effect. this drug has that also. So people sometimes have a lot of trouble overcoming that in the morning. Lower doses usually work for what we're wanting and will reduce that, that side effect. The last I put in here is there's lots of interest in fecal transplants for these folks. There is a good study that looked at patients with IBS, diarrhea, and mixed IBS, looking at donor fecal transplants, and found that at least in the short run, they had a lot of improvement in symptoms. It didn't hold as well at 12 months. Their symptoms returned. So there's interest in this. I think in your professional lifetime, you'll see a lot more interest in this and working towards which group of people are going to benefit from this kind of therapy. Probiotics, no advantage. Don't recommend them for IBS. You'll see some things about it that says it improves symptoms. Again, it goes to what organism, how much, how often, and does it get to the point of delivery? Are we looking at placebo effect, or are we actually seeing effect from the drug itself? Questions? Professor Rourke, do you want to add anything about the, did y'all do fecal transplant?
Yes. I learned all about them.
Oh, okay, so y'all talked about it.
Well, yeah, CDF.
Oh, with C. diff, yeah.
That's the only way you get it reimbursed.
Is for C. diff?
That I know of, yeah. And it's $40, you can go, sell your stool.
Oh, really?
Only in Boston.
Would you address with them what's going to be on the test and what's not? Because I didn't know you were moving different things to different. So is this, the GI potpourri stuff on this test?
Yes, so GI potpourri and IBS treatment.
Okay, yes.
But IBD will be on the next test.
Okay.
I stopped it about, I talked to him about that, at about,
Tuesday afternoon.
malabsorption syndrome, I think is where we ended it.
Yes.
So this IBD will be on second GI test?
Yes,
And then Hep C is on the next one.
correct. Yeah. So for Dr. Latassi's, it'll be, basically just for GI potpourri.
The nutrition.
Okay.
And nutrition, yeah.
Oh, that's right.
Professor Rowan, is the nutrition Clean Med or Pharm?
Is the what?
Like, yeah, how will be tagged on our test?
Clean Med. Do we tag those as Clean Med?
Wait, I didn't hear the very first part of your question.
Is your nutrition lecture tagged as Clean Med or Pharm?
Oh, it'll depend on the question. It'll depend on how I question it.
Okay.
So we'll send those out to you. Okay, why don't we just take a short break, and we'll be back at 1:45 we'll start, and we'll do IBD.